Good afternoon, everyone. My name is Andrew Watkins, and I'm the Director of Programs Innovation for Mindgardens Neuroscience Network. I'd like to importantly start out with an acknowledgement of country and lived experience. So firstly, to Aboriginal people, we'd like to acknowledge that the strength and resilience of both Aboriginal and Torres Strait Islander people, who are the traditional custodians of the diverse countries from which we're joining this meeting today. I'm privileged to be calling from the traditional lands of the Gubbi Gubbi people, and I pay my respects to elders past and present, and extend that respect to all Aboriginal and Torres Strait Islander people present today. I also wanted to acknowledge people with lived experience of mental ill health and recovery, and also the experience of people who have been carers, families, or supporters of those that experience mental illness. Welcome everyone to the Mindgardens Psychosis Webinar Series, which is part of the Mindgardens Tertiary Referral Service for Psychosis, or TRSP. Now, the TRSP, for anyone who might not be aware, is a statewide service funded by New South Wales Health and hosted by South Eastern Sydney Local Health District. Mindgardens is grateful to both CESLED and New South Wales Health for their ongoing support of TRSP. So the Tertiary Referral Service for Psychosis aims to improve the lives of people living with complex psychosis. It does so through delivery of a clinical service which welcomes referrals from right across New South Wales of anyone living with psychosis and receiving care from public mental health services. It also runs education and training programs to build capacity in caring for people living with complex psychosis. And this webinar series is an example of just that. This webinar series is supported by Mindgardens Neuroscience Network. For those who might be unfamiliar with us, Mindgardens is a partnership between members Neuroscience Research Australia, the Black Dog Institute, UNSW Sydney, and CESLED. Mindgardens was established in 2019 to enhance the collaborations between these members, bringing together clinicians, researchers, health service administrators, and people with lived experience to design, research, and quality improvement projects that can be translated into everyday practice, matching consumers' priorities and making a real difference in people's lives. This psychosis webinar will run throughout 2025 monthly, so please look out for emails from Mindgardens, which will detail future webinars, all tailored to clinicians. You can also have a look on our Mindgardens website for upcoming events, including these and other activities or education that we're running. Little bit of housekeeping for the webinar. You will see that a couple of poll questions will go up during my introduction, and there'll be a couple of more at the end. We'd really appreciate you answering these. Your answers will be anonymous, but they do help us constantly improve our webinars and deliver what you guys need. There'll be an opportunity for a Q&A session at the end. So please add any questions to the little Q&A icon, which should appear at the top of your Teams box there. We also appreciate any feedback in the chat window or by email. So if your question isn't answered or you'd like to share any suggestions for future webinar topics with us, please email us at our contact@mindgardens.org.au website. That's contact@mindgardens.org.au. This webinar will be recorded and distributed to all registered attendees within a couple of weeks. So please do keep an eye out for that. Finally, it's a great pleasure to introduce our guest speaker for today, Associate Professor Aswin Ratheesh. Aswin is currently Associate Professor of Psychiatry at the University of New South Wales, where he leads a program of clinical research involving prediction and intervention development in youth mood disorders. As part of his work, Aswin supported the development of and validation of one of the first clinical risk prediction approaches in bipolar disorder, and has led the development of a digitally supported early intervention model for youth with bipolar disorder, which is being evaluated further. Ashwin is also a psychiatrist and the James Packer Chair in Mood Disorders. As a psychiatrist, Ashwin has worked across tertiary and primary care settings, predominantly in youth mental health. He has led clinical programs in early psychosis and mood disorders. And if that wasn't enough, he is also co-lead of the Early Intervention Task Force with the International Society of Bipolar Disorders and is an associate editor for the Australian and New Zealand Journal of Psychiatry. Finally, he is executive committee member for the Australasian Society for Bipolar and Depressive Disorders and the RANZCP Committee for Research. Very busy. Glad that you could squeeze us in, Ashwin, because that is quite a commitment you've got there. Please join me in welcoming Associate Professor Aswin Ratheesh, presenting evidence-based treatments for bipolar disorder. Over to you, Aswin.
Thanks so much, Andy. And I should say that I have aged a bit since my last rather flattering image, but I'm sort of hiding in in my tiny corner, so presumably can get away with the with my gray hairs, which seem to have cropped up since my move to Sydney. Just very briefly, I'm a psychiatrist, and as Andy mentioned, I've worked for most of my time in youth mental health services, and most of that time in tertiary youth mental health services down in Melbourne, this place called Origin. And in the last 10 years or so, I've done a bit of research in early intervention. But today's talk is going to be much more focused on a general review of evidence base for treating bipolar disorders. But as I understand it, most of the webinar registrants were sort of general clinicians in tertiary mental health services. I'm going to try and pitch this much more towards a general clinician audience, but if you have very specific questions, please feel free to email me. I'm not going to focus too much on my own research, but again, very happy to talk to any of those issues if that's of interest to some people. I'll broadly talk about the conceptual issues around bipolar disorder as I see it, and then we'll touch upon acute treatment of mania, depression, and maintenance treatment. And I guess maybe I wanted to give you a taste of some of the new advances in treatment for bipolar disorder. So jumping into it, this is the sort of, obligatory statement around burden of disease. Many of you know that severe mental disorders are I suppose one of the most, the largest contributors to morbidity amongst young people and young adults. And amongst most mental health conditions, mood disorders, or I guess depression, is one of the biggest contributors to morbidity. Many of you work in tertiary mental health services, and if you do, one may think that most of the burden of disease is to do with schizophrenia spectrum disorders, but that's because tertiary mental health services often cater to about 0.5% of the population. Well, in fact, most of the burden of mental health conditions exist in about 10% of the population, 10 to 15% of the population, where depressive disorders and anxiety disorders predominate. But then after those conditions, it's really bipolar disorder and schizophrenia that are the most common contributors of years of life lost to disability, primarily because these are chronic enduring conditions. And I guess the biggest concern around some of these chronic severe conditions is, as you all very well know, is the premature loss of life. People with bipolar disorder and schizophrenia die about 10 years before their peers. Interestingly, in bipolar disorder, most of the excess mortality, or the highest peaks in excess mortality, are in the first 3 decades of life, and really in the first 3 to 4 years after diagnosis. This is somewhat older Swedish data, but it's fairly convincing that, and sort of proposes an argument for early intervention, at least if you want to avert mortality and morbidity. Now, I do come from an early intervention background, but I do believe that, I guess, long-term treatment for all people with severe and enduring conditions is important, and it's not all about early intervention. Early intervention is just one piece of the puzzle. I guess the other broad issue to be grappled with is, when do these conditions start? For a majority of people, the group of conditions that we refer to as bipolar disorder probably starts before the age of 35. If we look at people across the age spectrum, you see 3 peaks in the onset of bipolar disorder. The peak age is around, the first peak is around 18 years, and the second peak is around 28 years, around 30 years, and then there's a much smaller later peak. But if you put the first 2 peaks together, about 75–80% of the onset of bipolar disorder is before the age of 35 years. The other important thing to consider in terms of this condition, and you may notice that I refer to this as a group of conditions, is because we know that there are very significant differences amongst people with the same diagnosis. And it's true for all mental health conditions, not just bipolar disorder. There are very significant differences amongst people in terms of the clinical presentation, treatment response, but also what we know in terms of the genetic risk that's distributed in the population of people with bipolar disorder. But then also these conditions overlap quite a bit with depression and/or psychosis. And this is also probably your experience in working in tertiary mental health services. And a lot of people have diagnoses that change over time, or episodes that come and go and have different manifestations at different points in time. And that is supported again by the huge overlap in terms of clinical presentations, treatments, risk factors, genetics, and neuroimaging mechanisms. So really, I mean, there is an important role for thinking about these conditions transdiagnostically, but also thinking about the differences between groups within the same diagnosis. Which really means that, when you're talking about evidence, interpreting this evidence and translating that is critically important. So for most people with bipolar disorder, it's really important to think about their vulnerability, about how the illness is established, what is manifest, how the illness has progressed, but also what kind of problems have accumulated over time with the persistent effects of illness that we call maybe the allostatic effects. And then, of course, there's the person in front of you and their preferences and choices, their experiences of having developed the illness, having navigated the treatment, the variability in genetic factors that make some people more susceptible to side effects or have greater or lesser treatment response, their developmental experiences, as well as adaptive or compensatory mechanisms that have helped them to adapt or adjust to the condition. So really, when we're talking about evidence-based treatment of bipolar disorder, we are really talking about taking the bits of evidence that we have available and putting that in the context of the person's illness and the person themselves. Now, when you think about evidence for bipolar disorder, again, it's really important to think about the different phases of bipolar disorder and the goals of treatment. You don't have to focus on the text, which is obviously not visible, but it's important to know that the evidence and the data comes from clinical trials that are conducted in different phases of illness, and therefore really only apply to those phases. And therefore, what we can tell our patients in terms of what is efficacious or not really depends on the way in which clinical trials are done and the durations for which they are done. So the first pink section really talks about acute treatment, which typically is about a few weeks to a couple of months at most. Continuation treatment, typically for another few months, and then maintenance treatments, which last for much longer. And I'd like to point out that there are very few trials, or rather high-quality randomized controlled trials, that talk about long-term maintenance treatment of bipolar disorder, which means that a lot of our recommendations and a long-term management of bipolar disorder may not necessarily be evidence-based. Again, it's really important to know that the goals of the person or the individual can be incredibly different from the way clinical trials are done. For most people, they want a better sense of personal recovery or a greater improvement in their quality of life. And within that, there is, most people want to have greater sense of resilience from their illness, a return to functioning, and then symptom relief is often a much smaller part of most people's need, although it can be critically important at various phases. Again, so I'm talking about a mismatch between what the evidence base is all about, which is typically about symptom relief, and what people are often after. So again, sort of highlighting the limits of evidence. The next point I'd like to make is, I guess, it's about guidelines more broadly. There are a number of guidelines that I have pointed to here, and they vary in terms of their depth and therefore utility. For most clinicians, the NICE guidelines are fairly accessible one, but it's fairly old at this point. The Ransom Mood Disorder Guideline from 2020 is again fairly accessible, and it's probably the most current one that's available, although there's been some controversy about it. For psychiatrists and registrars, I would certainly recommend the World Federation of Societies of Biological Psychiatry, or FSBP guidelines. They're much more detailed, again, a bit older now. And then there's the Early Psychosis Guidelines, which have been updated about 10 years back. From the Australian Mood Disorder Guideline from 2020, there are a few tips that I would highlight at the very beginning, and these are laid out very clearly in the guideline. I would refer back to this, and I want to start by talking about these because a lot of the evidence really sits in the context of these, I guess, good psychosocial management principles. So really, it's centrally important to conduct a good assessment and to develop an individualized case formulation, without which most evidence-based treatments aren't practical. An important recommendation from guidelines, and that's fairly well supported by clinical trials, is the recommendation for active self-monitoring, typically using a mood diary or using apps these days. There are a number of apps that can be recommended, including one called Monsenso, which is a TGA-approved app, which can be used for both passive sensing as well as monitoring. Good quality sleep hygiene is, again, central to a number of circadian mechanisms in bipolar disorder and would be well worth your time. Online CBT, there are a number of online CBT resources that are available, including the original sort of This Way Up, which is based in Sydney. Healthy diet and exercise are central components for recovery, and we know that most of excess mortality has to do with metabolic abnormalities in people with bipolar disorder and schizophrenia, and addressing these through lifestyle interventions is, again, centrally important, and addressing smoking and alcohol can, again, go a long way in limiting mortality. Now, having talked about this, we'll jump into a little bit more of the detail of the evidence relating to acute mania, depression, and then maintenance. So really talking about acute mania, again, goals of treating acute mania, is again fairly well known to most of you guys as clinicians. Ensuring safety and minimizing trauma, supporting family members, care in least restrictive environment, and I guess minimizing risks, and especially if you are supporting someone who's choosing to stay in an outpatient setting, developing a good plan to limit the risk of embarrassment to themselves, overspending, sexual risk-taking are critically important. A lot of this can be achieved in some people, a minority of people who haven't yet lost insight or have such severe episodes. And it's well worth doing. And if it doesn't work in this current episode, it is likely to form the basis of future conversations that can help decrease risk in future episodes. But once someone is manic, the best recommendation is for a combination of a mood stabilizer and antipsychotic. We know that a combination of mood stabilizer and antipsychotic decreases the length of a manic episode even more than a single agent. Combination therapies are preferred for acute treatment of mania. We generally talk about monotherapy and limiting number of treatments. For acute mania, polypharmacy and polytherapy is the recommendation. And in fact, many of you working in inpatient settings know that 2 to 3 medications are the norm. That is not a bad thing. That is what is supported by guidelines. Now, this is a multiple treatments meta-analysis that ranks a number of these interventions in the order of their efficacy and tolerability. It may be hard for you to see the detail, but the point is that for most trials in acute mania, high potency antipsychotics, as well as sedating antipsychotics like olanzapine and quetiapine, so high-potency antipsychotics like haloperidol and risperidone, or olanzapine, quetiapine, and lithium are some of the most effective agents. But haloperidol, while it's more effective in these multiple treatments meta-analysis, has lots of side effects and therefore has got poorer, overall tolerability. These multiple treatments meta-analysis also have these problems that they equate all randomized trials. Trials done in the 1970s aren't the same as trials done in 2000s. So there are some differences, so that this is not foolproof. There is an updated multiple treatments meta-analysis that again reflects similar findings. The most common agents, most efficacious agents seem to be risperidone, haloperidol, olanzapine, cariprazine, quetiapine, aripiprazole, valproate, and lithium. Tamoxifen at the very top, I'm not quite sure. It can be a general recommendation. It's from a few small trials. Carbamazepine also comes up as fairly effective, again from older trials. And this is in terms of response to treatment as the outcome, but if you think about all-cause discontinuation, olanzapine and quetiapine really come up as the 2 most favorable agents for treating acute mania because people are less likely to stop these medications because of side effects. Clearly, sedation is of benefit in acute treatment of mania. Again, the next important part, especially in the inpatient setting, is managing acute agitation. Many of you know this incredibly well. It's really important to focus on non-pharmacological strategies and sensory management, but the recommended oral medications for management of agitation are asenapine, quetiapine, haloperidol, and risperidone. Olanzapine, also used as a wafer, can be pretty helpful for managing agitation. As an intramuscular agent, olanzapine and haloperidol are most commonly used, as was benzodiazepines, again, very commonly used. Aripiprazole as an IMI is also not the long-acting version, but there's a short-acting version, which I don't think is marketed in Australia, is another recommended treatment option. ECT is, again, very effective in acute treatment of mania. Here, this is a recent meta-analysis that suggests that as few as 3 to 5 ECTs, but definitely by about 9 to 10 ECTs, you get a very strong benefit of ECTs combined with medications over medications alone. But again, this meta-analysis also suggests that ECTs have a higher risk of memory impairments, and we know that a range of memory impairments are common with ECTs, including both short-term memory loss as well as autobiographical memory loss. So ECTs have to be used cautiously, but can be an incredibly effective treatment agent, I should say. Now, let's switch to acute treatment of depression. Now, for most people with bipolar depression, they're treated in general outpatient settings, with a few people with very severe episodes being treated in inpatient settings. And in those situations, some of these recommendations may differ. But the general approach would be to try to anticipate episodes of depression. Many of you probably know this, that with people with fairly severe bipolar disorder, about 40 to 50% of their week-to-week time can be spent in subthreshold or threshold depressive episodes. And therefore, a good understanding of someone's life patterns and or known episodic patterns after manic or hypomanic episodes should help you anticipate for depressive episodes. We also know that depressive symptoms as part of, or depressive episodes as part of bipolar disorder can sometimes be different from depressive episodes as part of unipolar depression in terms of characteristics such as atypical depression, psychomotor changes, as well as patterns of onset and offset, which also mean that sometimes psychotherapeutic agents, psychotherapeutic approaches may have to be modified or may work a bit differently from those with unipolar depression. You also probably know that a big component of most treatments in randomized controlled trials is expectancy effects. So it's incredibly useful to provide a message of hope. Again, heterogeneity is the norm, both in bipolar depression and in unipolar depression, and therefore individualized formulations are central, and they also help you understand contextual factors that can help you overcome barriers to treatment. Now, in terms of pharmacological treatments, the most common recommendations for bipolar depression include, I guess, optimizing mood stabilizers. So this is a recommendation that came from the STEP-BD, fairly large trial from about 10, 15 years back now. The other recommendations are to use monotherapy or augmentation with low doses of atypical antipsychotics such as quetiapine, lurasidone, or cariprazole. When I say low doses, typically we mean 20 to 40 milligrams of lurasidone, about 150 milligrams of quetiapine, and up to 1.5 milligrams of cariprazine. So really low doses. There is no benefit in increasing the doses. In fact, potentially there may be an adverse risk-benefit balance with higher doses of these agents trying to treat bipolar depression. This combination of olanzapine fluoxetine is approved and marketed in the US, which was fairly effective in a very large trial that was done by Eli Lilly, but it's unclear if this cannot be replicated with another combination of an SSRI and another sedating antipsychotic, such as quetiapine, for example. Adding antidepressant is a reasonable option so long as a mood stabilizer is on board. Now, this is likely to work for some people. On average, there may be the effects may be quite mild, and this doesn't come up in randomized trials mostly because of heterogeneity. Again, repetitive TMS or rTMS or ECT are good options for treating bipolar depression as well. Centrally important to monitor for switch, but switch rates are low. Only about 20% of people even with bipolar disorder will develop a switch. It's much more likely that people continue to have persistent depression, and it's really important to monitor for these symptoms and to try and address these, often with a combination of psychological therapies and formulation-driven approaches to address barriers to recovery. Just very briefly, this is a recent, again, multiple treatments meta-analysis that looks at the comparative evidence of medications. So I apologize, some of the font is pretty small, but the most effective medications seem to be antipsychotics and a combination of antipsychotics and antidepressants. Now, these are medications with a bit less evidence, but also different from placebo in these meta-analyses. But I won't go into the details of these. But this summary slide is a bit more useful. Broadly, a combination of an antipsychotic plus an antidepressant is much more effective. Alternately, low-dose atypical antipsychotics and or antidepressants can be reasonably effective. Antiepileptics, potentially also useful. The evidence for lithium is a bit less strong. Now, what about psychological treatments? Now, I guess all psychological therapies are complex interventions. They have multiple components, and each component has a different or sometimes overlapping and interacting mechanism. And it's central to, again, develop a formulation that addresses the components that are specific to the individual. But if you look at the specific psychological therapies, it's CBT, family-focused therapies, and interpersonal social rhythms therapies that have some evidence. CBT potentially has slightly more evidence than family-focused therapies and IPSRT, but then one may achieve a lot more effects by addressing comorbid conditions such as anxiety as well, for which there is very strong evidence. In terms of the evidence data, this is from multiple treatments meta-analysis that David Miklowitz led a few years back. And they essentially looked at, again, the detail is not important. I'll come back to that in 1 second. But basically, this meta-analysis suggested that CBT was better than treatment as usual, both in combination with medications in preventing relapses of bipolar disorder. But then the other useful thing from this meta-analysis was they looked at all the different components of what is effective and what's not, and they found that a family or a group format, as well as monitoring for early warning signs were useful. Guess moving on to maintenance treatments, I'd like to mainly highlight the issue that most data on maintenance treatments comes from extension phase trials of antipsychotics that typically last for about 6 months. It's only really mood stabilizers that, so typically lithium valproate and lamotrigine, that typically have longer term trials. The short-term trials of antipsychotics are typically continuation phase trials. That means that this is a guideline recommendation from the 2015 Australian Clinical Practice Guidelines, which says essentially that you should review whatever treatment the person is on every 6 months and review the balance of efficacy versus tolerability, quality of life, functioning, side effects, and so on and so forth. And this is because most of the data that underpins these recommendations or the clinical trials typically last for about 6 months. So really every 6 months, one should be reviewing the role of each individual medication and reassess that in terms of the benefit-risk ratio. Now, I will refer you to the clinical practice guidelines. Very brief summary is that if you exclude enriched trials, it's really only lithium that stands out as a good quality maintenance treatment for long-term maintenance treatment of bipolar disorder. But if you allow for enriched trials, aripiprazole, cariprazine, olanzapine, and quetiapine have 6-month continuation or extension phase trials that support continuation for at least 6 months. But then thereafter, it makes sense to review their efficacy and tolerability. Now, predominant polarity is an important issue. So if someone has a predominant depressive polarity of illness, there may be a good value in considering lamotrigine and or lithium, because they have both effects on depression and or mania as well. I want to highlight 2 randomized controlled trials that have been published in the last 5-6 years. And this first, both were done by Lakshmi Yatham. This really addressed the question of how long one should continue an antipsychotic after remission. The short version is 6 months. It seems like there's no benefit for continuing an antipsychotic along with a mood stabilizer beyond the 6-month mark, because people clearly gain substantial amounts of weight and or have other adverse side effects. But if you stop the antipsychotic too soon, so within the first week or so of remission, they're much more likely to have a relapse. So as we were talking about this acute treatment of mania, combination therapies are the norm. How long would you continue an antipsychotic? Roughly for about 6 months. Mood stabilizers typically for longer. And that would again be a risk-benefit discussion with the person. Now, this is a very new trial that was published in NEJM last year, looking at how long we should continue an antidepressant after remission. The headline finding was that there's no difference. Sorry, they tried to stop the antidepressant after 8 weeks or after 1 year. The main finding was that there's no difference if you stop the antidepressant after 8 weeks versus 52 weeks. But if you look at the time to relapse to depression, and if you look more in a bit more detail at the trial, you see that the baseline they picked made a difference. There could be an argument that could be made to continue antidepressant for a longer time if depression has been a big part of someone's life, and it's critically important to prevent a significant depressive relapse. So this trial is starting to suggest that there may be some value in continuing antidepressants, although the headline finding from the trial is that there's no difference between groups. Now, I just want to make a brief point about what one of my colleagues, Professor Greg Murray, talks about as capital P psychoeducation. So the general idea of psychoeducation, talking about illness and recommending good things is referred to as small P psychoeducation, or this idea of providing good recommendations. But in bipolar disorder, there's this idea of a formalized psychoeducation, which really focuses on education regarding relapses, self-monitoring, addressing circadian rhythms, and a strong focus on medication adherence. And this, delivered in a group format, has pretty good evidence in preventing relapses. Again, critically important to address anxiety and substance use, because these are very common, and good quality CBT can help address anxiety and can go a long way in keeping people well. Motivational work, CBT, and or brief stints at detox and or long-term residential recovery may be critically important for some people. You know that bipolar disorder has got the highest overlap with substance use. People with mania, it's a surprise that they don't use substances. And that's partly the genetics of this condition, but partly the way in which manic episodes contribute to disinhibition. And so it's critically important to address substance use. There's some evidence that suggests that valproate may be more efficacious in people with bipolar 1 disorder if they also have comorbid substance use. I want to make a brief point about ADHD. There are at least a couple of good quality registry linkage studies that suggest that if people have bipolar disorder, if they're not on mood stabilizers, they have a much greater risk of new onset mania, both for methylphenidate and for amphetamines. For amphetamines, higher dose amphetamines were more risky, so more than 30 milligrams of dexamphetamine was associated with a higher risk. But if they're on a mood stabilizer, the risk was lower. But there is one other study that suggested that the risk may be lower. A Danish study that suggested that risk may be lower, even if people are off mood stabilizer. But on balance, one would suggest that if someone has got bipolar disorder, they should be on a mood stabilizer before starting ADHD treatments. Now, before I finish, I just want to briefly touch upon a few new advances regarding medications and briefly about a piece of work that I've done. I wanted to briefly touch on a medication that is very commonly used, I guess increasingly commonly used for schizophrenia, which is cariprazine, which is a partial D2, D3 agonist. It's got some, I guess, mechanistic advantages over some of the newer atypicals. There are a few trials in acute mania and mixed episodes, and 3 trials in bipolar depression. Seems to be effective for both mania and depression. Aripiprazole 2 monthly injections are again marketed in Australia now. It doesn't seem like there's any difference in efficacy in prevention of manic episodes in people with bipolar disorder. This has been trialed in people with bipolar disorder as well as schizophrenia. In general, for most of these conditions in Australia, they only request regulatory approval for schizophrenia, but also effective for bipolar disorder. And it seemed like there's some suggestion that there was better subjective well-being with the longer acting agents, but 25% of the 2 monthly injection group had injection site pain. Obviously, it's a bigger injection and therefore more likely to cause injection site side effects. This is a medication that's not available, but seems very promising, seems to have some SSRI-like pharmacodynamic effects in addition to antipsychotic effects, but not marketed in Australia. This is an alpha agonist. It's an anesthetic agent, but available as a sublingual patch. New trial in JAMA last year that suggested that 180 microgram dose can be effective in decreasing agitation in people with mania or hypomania, also in people with agitation as part of psychosis. But again, unfortunately not available, hopefully available at some point. Also want to briefly touch upon the role of early specialized interventions. This is the work that I've done for the last few years. Basically, because bipolar disorder is less likely to have cognitive impairments at baseline, the hope is that one can intervene early and at least prevent the progression of illness, and particularly in terms of cognitive and or illness-related allostatic effects. So we essentially developed a model of care for young people with bipolar disorder, nested in a digital framework. But in this model, we wanted to address some of the circadian and recycling abnormalities. But it was really interesting that in collaboration with young people, we kind of worked on this idea that you could tolerate imperfect control of mania and or hypomania. And I want to talk about this, at least for young people, because for most adults, the goal is to try to prevent manic relapses. And we aim for tight control of mania, but often at the risk of contributing to onset of depression. So this is something to consider, that this may be a conversation to be had with people about the degree of perfect control that you may want to achieve regarding mania or hypomania, because in young people in the earlier course of illness, it may be possible to have some more flexibility in the risk that you may take with the risk of mania or hypomania. We developed this model of care for young people that included an online social therapy component, some digital components, which were bipolar specific, and then as well as non-specific components, and included some guideline concorded pharmacotherapy. And we tested this in a pilot randomized control trial. I just wanted to also give you a taste of some of these digital tools. We developed these tools working with young people with the lived experience of bipolar disorder, very much from a positive psychology perspective, trying to provide psychoeducation. This is sort of in a graphic novel format with these 4 young people, and they sort of go on these journeys together. And ultimately, all these comics can be sort of printed off to create a graphic novel that after the sort of 4 to 6 month treatment, people can take away with them. But they also had lots of different components of care. As I mentioned in the previous slide, we did a pilot trial and found that generally people who received this sort of blend model did a bit better than people who received comparison standard care. And it's just been published last month. Now, I do want to finish by talking about, I guess, the fact that evidence base really only covers, I guess, a proportion of what we want to cover in terms of a comprehensive, good quality, comprehensive treatment plan that people deserve. But evidence should inform whatever part of these treatment plans that are applicable to the person and for which evidence is available. And we should use that evidence to try to provide the best quality care in collaboration with consumers, and ideally using a shared decision-making approaches. Now, I might finish there and take questions for the remaining time.
Thank you so much, Aswin. That's a fantastic presentation, really deep dive into the evidence around bipolar disorder. As people take the chance to put questions in the Q&A chat, you can also, if that's not working for you, you can also add into just the general chat line any questions. But could I just wanted to really highlight one area that I think really stood out for me from your presentation, and that was around you really emphasised the importance of not setting and forgetting medication regimes, that regular review and the importance of individualisation and how the course of the illness may change substantially over time. So that's something that really resonated with me. I did just want to check with you, Aswin, for the audience. When you referred to the evidence on bipolar disorder. Now, was that for bipolar 1 or combination of 1 and 2? And tying into that, question that we have from the audience is around, is there a movement away from that differentiation between bipolar 1 and bipolar 2?
Thanks, Andy. I think that's a really important question around bipolar 1 versus 2. The clinical trials tend to combine bipolar 1 and 2. Now, that means that most of the evidence really translates to both bipolar 1 and 2, except, I guess, in terms of the acute mania trials typically only refer to bipolar 1 because obviously hypomania is less of an issue. But even the dexmedetomidine trial included people with hypomania, so it includes both bipolar 1 and 2. Having said that, there is an increasing amount of evidence that suggests that the genetics of bipolar 1 and 2 may be quite different, and the bipolar 2 may be fairly close to major depression. Now, again, these distinctions probably disappear when you're thinking about this from a genetic risk point of view. And the risk genes for these conditions are probably inherited as a handful or a few hundreds, and they may come in various combinations, and a number of those combinations contribute to the development of a more classical bipolar 1 picture, and then another combination might, along with, I guess, developmental experiences and life experiences, contribute to the development of a bipolar 2-like picture. But there are lots of shades of gray in between, and I think so there is a validity to some of these distinctions, but we should not think about them as true distinct entities with clear margins. There are lots of grays in between. But the evidence broadly refers to both 1 and 2 together.
Yeah, no, thank you for clarifying that. I think it's an area where it can be quite diagnostically difficult, particularly in the early phases of illness. Another question that we've had come in and was around whether there was any evidence that currently existed around using a ketogenic diet for treatment of bipolar disorder. This is something that I think clinicians are hearing more about from consumers and carers as to whether that might benefit treatment like for an illness like bipolar disorder?
I'd say there are a number of trials that are ongoing that I'm aware of, but I would not say that there is good quality evidence enough to recommend ketogenic diet. It's quite possible that some of these diets are more efficacious for some people than others. At a group level, unfortunately, there isn't enough evidence. There may be general metabolic benefits for a ketogenic diet, and there are, I guess there is accumulating evidence for that, but that's not necessarily to say that for people with bipolar disorder, it's going to specifically improve mood symptoms.
Yeah, and there's a question that probably has a similar answer, I imagine, but asking about the benefit of fecal transplants. So that's quite early in the research phase, maybe a benefit, but we don't have the evidence. Is that how you'd frame it?
Exactly. And there is an understanding that at least for a subproportion of people with bipolar disorder, but as well as a number of these other conditions, there are changes in gut microbial flora, and that may be connected to the general inflammatory state that we know is common in people with bipolar. And there may also be links with the circadian system. And so these may all be connected, and it does make sense that there are gut alterations. I mean, clearly the body exists as a unitary entity, and all of these components are important, but it's more likely that it's effective for some and not for all. And I mean, that's the case for all interventions, but we need to probably find out, who it's more likely to work for.
Right. And there's a question here around you mentioning that mania or manic episodes are best treated by medication combinations. And this person's observed in their practice that people may become non-adherent to their medication regime due to the feelings of euphoria when manic. You recommend how this could potentially be addressed by psychological therapies?
That's a really good question. Over the years, I've had some patients who followed up in private practice for about 10 years, and even in our tertiary mental health settings, we've had some young people who we've who sort of stayed manic for up to 2 months in an outpatient setting while avoiding, I guess, hospitalization. And my take on this is that the level of insight can fluctuate in bipolar disorder, and it's not that people are completely insightless and then completely insightful. As most human beings, I guess our level of cognitive control varies, even just during the day. And so it's the same with people with mania and bipolar disorder. And so their degree of intent to take medications, but then I suppose is weighed up against a number of other factors that means that they don't want to take medications. They feel that they may cause side effects. They'd rather stay a little bit high. They're afraid of feeling low and or depressed. Now, the degree to which it can be addressed through psychological therapy really depends on that fluctuating level of insight and how someone can be brought on board. And that also relies on your therapeutic alliance with the person, how much they trust you, and how long you've had that therapeutic relationship for. So it's obviously a complex issue, and but certainly one worth addressing through psychological therapies, if possible, I would say.
Yeah, did very well. It's a very tricky one to answer in this format. I think we could give you 2 hours to answer that one and we'd still be having an interesting discussion. There's a number of more questions, but we've only got time for one. So for those people we didn't get a chance to answer those questions, we'll endeavour to put those questions to Aswin and come back to the group in our when we share the presentation with answers to those. But just as a final one, Aswin, it's around fish oils and omega-3 and around what evidence there is for that and whether that evidence gets to the point of offering a recommended therapeutic dose.
The general trials for fish oil across a number of conditions seems to suggest that these omega-3 fatty acids are important. It makes sense to try and get these fatty acids from diet as much as possible. So oily fish and or regular consumption of fish is critically important. It seems like the supplementation probably has more evidence when you study this in landlocked areas far from the sea where people don't have adequate consumption of fish. And in those settings, there may be value in fish oil supplementation. But on balance, there's no evidence to suggest that fish oil supplementation is good for the general population of people with bipolar disorder. So unfortunately, there isn't a dose to recommend, but for most studies, you're really looking at 2 grams or more of a combination of EPA and DHA per day, which often works out to be several capsules of high-strength fish oil. But really, most recommendations are moving towards trying to have adequate fatty or oily fish in your diet. But of course, also noting that there are some environmental concerns, and also it's not often sustainable, and it can be expensive. So definitely some challenges there.
Yeah, no. Thank you for clarifying that. I think it's important to note. I mean, I think we held a lot of hope a decade or so ago around what fish oils might be able to do, but it doesn't seem as though the trials have shown too much benefit there. Could I get everyone to give a virtual round of applause for Aswin today and his fantastic presentation and willingness to answer all the tricky questions as well. It's been brilliant. We look forward to welcoming you to the next webinar in September. That will be announced very shortly. And don't forget to send us feedback, including your suggestions for future webinar topics, to our email address, contact@mindgardens.org.au. Lots of appreciation coming through on the chat line, Aswin. And thank you very much once again.
Thanks so much for having me.